oral hygiene is one of the most difficult personal grooming things that exist in life. All I'm asking you to do is pop this tray in.
Yeah. Yeah, it's pretty simple. This episode is brought to you by our friends at Perio Protect. Are you tired of endless cycles of battling gum disease? Our sponsor, Perio Protect, introduces a groundbreaking solution for patients with periodontitis, gingivitis, and with halitosis related to gum disease. The innovative Perio Protect Method provides a home care solution to complement periodontal therapy in your office. How does it work? The patented Perio Tray is a customized fit to your patient's unique dental structures. Seals in medicament perio gel delivered to precisely where you need it the most, deep into periodontal pockets. Patients just wear the tray for 10 to 15 minutes a day with the gel inside. It's easy, comfortable, and feels great. Perio Tray medicament carrier is patented and FDA cleared as a medical device, so it should always be manufactured by Perio Protect to get the proper seal system for reliable results for every patient. Perio Protect is backed by years of rigorous research ensuring reliable results every time. Visit providers.perioprotect.com to learn more and discover upcoming continuing education with the links delivered below. Thanks, Perio Protect. Welcome back to another episode of the Tooth or Dare podcast. Peeps with your peep, Irene. Hello. It's a pleasure to be here. Where are we? We're in not so sunny California at CDA Anaheim. And from what I hear, it is pretty customary of this time of year to be quite gloomy and cloudy. Correct? I'm joined by two wonderful guests here at the Perio Protect booth. So thank you to Perio Protect for sponsoring this episode and for sharing your innovations with us and the many people that walked by while we were here earlier. I'd like to welcome Craig to the podcast and Dr. Lau to the podcast. We're going to talk about perio stuff. How are you doing today?
Doing great.
Yeah?
It is a little hazy out there, but
it is. For a curly hair girl, it's not so good.
Yeah, it's not a good hair day.
How about you?
I live in Florida.
Which part?
Northeast on the ocean.
Northeast on the ocean. Any particular city?
Between Daytona and the oldest city in the United States.
So it's sunny all the time there, right?
No.
Not quite like here, though.
Here is probably more consistent weather.
Okay. And what about you, Craig? What's your location?
Yeah. So I live in St. Louis, St. Louis, Missouri, in the very middle of the country.
Okay.
So any weather is better than that weather. So it doesn't matter if it's cloudy outside. I can kind of smell the ocean here. There's like that scent of the ocean. I don't smell anything like that in St. Louis.
What do you smell in St. Louis?
Just like factories and mud and corn.
Cows. Corn.
Yeah.
Corn.
Like,
okay.
Sometimes garbage. I know. I'm just kidding. St. Louis is amazing. It really is an amazing city.
This is going to do well to get people to St. Louis.
Yeah, no. Well,
yeah,
hey,
I
want to keep them out because I want it all for myself. So I decide down talk it so I can live there and keep our housing costs low.
Oh, well, that's good. Housing costs are pretty crazy. I'm in the city of Toronto and the housing is just astronomical.
Yeah, I can't imagine. Yeah.
But we're not here to talk about the weather. And we're not here to talk about St. Louis, although it sounds very appealing and I'm very excited.
We have a zoo.
You have a zoo? Great. We're going to link the link to the zoo in the show notes below for anyone that would like. It's free on Thursdays. No, I'm just kidding.
Only Thursdays.
We're here to talk about perio and pathogens and bugs. And we have a little bit of a twist that I'm going to throw into this, incorporating Perio Protect into my practice for the first time as a new provider. And Dr. Lau is lecturing on perio tomorrow and a variety of other things, not just perio, but I'd like to get your insights on what your journey has been. You have a very distinguished career. What's led you to where you are today? And maybe we start there.
Sure. And as you can imagine, periodontics has taken its twists and turns over the last 3 or 4 or 5 decades. At this point, I think we are probably in a major change in the way that we look at everything. Everything has sort of been focused primarily on just, as we say, on, on the bugs. Kill them all, take no prisoners.
Kill them all, take no prisoners.
Yeah.
I love that.
And now there's a lot of thought that you would never do that in the gut. So why would you do that in the mouth?
Right. Yeah.
And as we talk about the oral microbiome, the gut microbiome, we're where gastroenterologists were about 10 to 15 years ago.
Interesting.
So things are changing.
So we're not ahead. We're behind.
Dentistry always runs about 5 to 10 years behind medicine.
Why do you think that is?
We're not real doctors.
Hot takes.
Dun-dun-dun.
No, there's always been a schism between medicine and dentistry.
Yeah. You're not wrong. Yeah.
Yeah.
Absolutely.
Our running joke is that, what does a physician think about a dentist? They couldn't get in medical school.
Yeah.
Although at this point, if you look to see who is making the most money in the less stress-free environment in the United States, it's by far oral health care.
Interesting, because I feel like I am at my highest peak of stress level. I can only imagine what anything higher than my current threshold would be.
Well, I think that's the nature of your generation.
Perhaps. My generation. What
Yes.
What generation do you think that is? How old do you think I am?
Be
This is
careful.
a hot take. No,
Be
it's okay.
careful.
Take no prisoners.
You're probably a millennial.
I am. I'm an elder millennial, though. I'm on
Exactly.
the cusp. I remember the days with dial-up internet.
Yes.
Yeah.
Same.
And no internet, but yeah.
Right. But see, I guessed
Yeah.
it, didn't I?
You did.
I do a
Can we get a slow motion of that wink that he just gave me too? I guess it didn't.
I do a half a day on generational dentistry
Uh-oh. I don't want
about who we are and who our patients are.
to. Yeah.
And so, yeah, I mean, it is. My granddaughter's a Gen Z, and she's different from you.
She is.
And Xers are different, and
Yeah.
baby boomers are different.
Yeah.
But right now, the generation that has most periodontal disease is going to be the baby boomers.
Yeah.
By far.
Absolutely. So tell me about your history. So are you a periodontist? Are you a general dentist? Tell the viewers
Sure.
at home a little bit about your experience
Right.
and
Well-
what's led you to the podium.
It was circuitous. I started out as a high school biology teacher,
Huh.
went to dental school in Texas, and was trying to decide between oral surgery and periodontics. I love surgery, but I also love managing patients. I really enjoyed being with patients. And so I also made a decision that I could also, maybe it was because of the high school biology thing, that I could get into academics but still practice.
Mm.
And so I was at the University of Florida for a few years. But I have always enjoyed relating to people and speaking and, trying to appreciate that what they do on Monday might be changed by something I might say.
Hmm.
And I've gotten fairly good at it.
That's great. Tell me about your perio practice. Are you still practicing?
I stopped in a few years ago and decided to go into consulting.
Oh, okay.
And I still, however, keep my hands wet. I'm a laser periodontist. So I'm an attending at the University of Florida College of Dentistry, but primarily laser. I got into lasers 2009 when it wasn't okay for periodontists to get into lasers.
Mm.
But we're there now, and I think that we're moving forward. So,
Do you prefer laser as in diode or as in CO2 or both?
depends upon who you are. If you're doing non-surgical perio, there's absolutely no reason why
You'd use a CO2
a
laser.
great diode is very effective.
Right.
However, if you're talking about doing periodontal surgery, and especially around implants, it's going to be erbium
Yeah.
because it's the only wavelength that effectively can do both hard and soft tissue.
Hmm.
But lasers, I do believe that there will be a time, you wouldn't go and have eye surgery done by an ophthalmologist unless they had a laser.
Hmm.
You definitely wouldn't have any derm work. And so eventually that's what you're going to see here.
Yeah. So tomorrow you're lecturing on periodontal treatments
Mhm.
in a post-antibiotic world or
Correct.
era. Is that the title? Did I get it right?
It's,
Close enough.
Age.
Age.
Post-antibiotic age.
Post-
to be
Post-antibiotic
frank with
age.
you, I'm not even sure what
I don't even remember what the learning objectives were.
I don't either, because I will probably put it together.
Don't tell anyone our speaker secrets. They don't need to know.
No, I mean, it's
They
true.
don't need to know we put our lectures together on the plane right here.
But there's a reason for that.
Well, it's just, science is always changing.
That's what we tell people.
By the time you get to the from the airport,
that's what we tell people.
No, it
when
is.
When the conference organizers say, "Can I please get your?"
No,
your...
some people think that you're being a little lax, but if you do it, if you put your thing together right before you present, you're charged.
It's fresh.
You're charged.
Yeah, it's fresh.
I don't take anything out of the can.
Yeah,
it's charged. So tomorrow,
tell me about your lecture.
It's quite interesting. We've been in an antibiotic age for decades. I'll give you a quick example. If you look at the United States, we are considered to be 45th in antibiotic resistance.
Yeah. 45th.
Right.
In antibiotic resistance.
We're like in the 40 percentile in the number of antibiotics we give.
Yeah.
Finland, let's go across. Finland is number 1 in antibiotic resistance, and they provide the least prescriptions for antibiotics.
Is it a genetic thing, or what is it that I don't follow?
They're smart.
They're just
the Scandinavians in Perio, the Scandinavians have always been way ahead of us.
Okay.
In the fact that using common sense. But we've got situations now where someone just wants to write a script. And what we're doing, in addition to agriculture, that's a whole nother animal.
Yeah.
Literally. But if you look at the food that we eat,
yeah,
whether it be, fauna or flora, it's laced with antibiotics.
Yeah.
So if you look at like children, if you talk to a parent years ago with a child that had otitis, certain antibiotics didn't work. And then a few years later, another antibiotic didn't work. The same thing has been in Perio. We started out with tetracycline.
Yeah.
We never use tetracycline now. Why? Everyone's resistant to it. So we're going to run. So it's not just about dentistry, is it?
No.
It's about us. There's going to be a time we're going to wish that we had an effective antibiotic. And there's not going to be one because we built this resistance. Our bugs were here before us. They're going to be here after us.
Yeah.
They're going to survive. They're going to live.
So what would you say the most efficacious form of periotherapy or maintenance is if you were to put together a protocol and say, these are the things that every dental hygienist or dental office should have in their back pocket, taking away the uses of antibiotics or oral antibiotic rinses or intersulcular medicaments? What would you say is an essential thing that every practice should do?
Right. Well, I'm glad you mentioned hygienist. It would be extremely naive to ever think that the number one individual providing periodontal care in North America is the dental hygienist. It's not the periodontist. In fact, unfortunately, many periodontists are doing more implants and not managing perio.
Yep.
So who is that individual? It's going to be the dental hygienist. And now if I go back and look at because being a periodontist, we're a little anal when it comes to research. But when you go back and you look at every study ever done in managing perio, you know what it comes out to? It comes out to a dental hygienist knowing root anatomy to be able to disrupt the biofilm every 3 months. And the number one perio procedure of all, scaling and root planing. Now, I hate calling it scaling and root planing.
Right.
Scaling, that means, what are you doing? You got scales?
We're taking a fish and we're
exactly
hitting it over the head and then taking off its scales.
I mean, think about this. Jane, today we're going to do a procedure called root planing.
Sounds horrible. Are we making a table? What are we doing?
No, I would say...
Is there a machine?
Right. It's like woodworking.
Yeah. We're whittling down the top of a table to plane it.
About 15 years ago, I began to push a different terminology called debridement.
Yes.
And guess what? The European Federation of Perio in the last year has eliminated scaling and root planing from their glossary, and they have in their debridement.
Yeah.
So,
Well, we don't want a root plane anymore. I think that's an old and archaic philosophy that the glassy roots of, and that's what I learned when I was in dental hygiene. I've been practicing for 17 years now, but that's what they taught us. They taught us that you need to make cementum smooth and as smooth as humanly possible, and that it shouldn't feel rough at all.
and we had no science.
And we had no science. And so we had some science, but not nearly as
Not the science.
as detailed as the science that we have now.
Right. I always say the mission of a dental hygienist in root planing is to try to find the pulp before the patient dies.
Oh gosh. Yeah, I've seen those x-rays. They don't look good.
Yeah, I mean,
what should every dental hygienist have in their back pocket for that appointment?
let's become diabetologists, gastroenterologists, cardiologists. Let's start managing the flora and be smart about it in delivering something that will not create resistance forms,
Right.
an antimicrobial instead of an antibiotic, but also find a way to deliver it. The bottom line is this. There's not a thing in this exhibit hall that you and I can use in oral hygiene that's going to get past 2 millimeters in a sulcus. Every study shows it. There's not a single thing in here.
I mean, a laser.
A patient. I'm talking about at home.
Oh, I mean, you mean home care. Got it. Okay.
Yeah. I'm talking about home.
Got it.
So, I mean, what we do at the chair is one thing, but where we're trying to move away from is we started at the chair, right? We just talked about debridement. But how does the patient maintain it
Right.
after they leave here?
Sure.
Local delivery antimicrobials.
Right.
Let's just be frank. They are very effective for 2 to 3 weeks. The organisms recolonize. Why?
Right.
They're in survival mode.
Are you talking like a minocycline?
I'm trying not to say the brand.
I said minocycline. That's not a brand. So are you saying like
So,
a
I'm
minocycline?
But you
Keep it
keep
at one
trying,
word,
I'm
yeah.
just making sure.
It's okay. I mean, I think it's
We're
important
understanding,
that we
yeah.
do say names and brands, and it's not
I do too.
it's not a disparaging
But I don't
thing.
know you.
Yeah, it's not a disparaging thing to, I think if you think about it, the people that are listening are dental hygienists driving to their office wondering, is it what I'm using in my practice? Is this efficacious? Is it scientifically driven? And they don't know because most of the time, and I'm a dental hygienist, but I also own my own practice. So I have a different philosophy when it comes to what I stock in my operatories. Most dental hygienists don't have that luxury. They don't have the luxury to say, well, I don't want to use this because I don't think it's scientifically proven. They will have to concede because the dentist or whomever the practice owner is putting that on the table and saying, you need to do this. And sometimes it's for billable purposes, not particularly for patient purposes. And I hope that's not the case, but the reality is that it is. So it's not a bad thing if we say minocycline. It's not, I mean, we're not throwing anyone under the bus, but we're having a discussion on what is the most effective thing for dental hygienists to be doing for those chronic perio patients.
Well, there's never been a systematic study that's ever demonstrated that putting something in a sulcus at the chair is effective. Because the bugs are there because they like it. You can't, it's a joke, and Craig has probably heard me say this, but we always say something like, the only way to sterilize a mouth, put the patient's head in an autoclave and turn it on. The only thing I know.
Which cycle would we use for that? Is it 100? Is it the wrapped cycle?
Depends if you're in Alberta or you're in
I like the speed
Ottawa.
cycles for unwrapped and not solid.
That sounds
134 degrees for like what? 14 minutes. Okay.
14 minutes. Yes.
14 minutes. Is that what that is? Okay, so we've figured that Dr. Lau doesn't like anything other than scaling and roof planing.
Well, but I want to complete when the direction we were going here is that when I mentioned there's nothing in here that's going to get more than 2 millimeters.
Got it.
So if I have a perio patient,
So what do we do?
how do I get a medication beyond the 2 millimeters?
Right.
And that's what this is all about.
Perio Protect.
Exactly.
Got it. For those of you listening in your car, he just nodded. He did the head nod.
Yes.
A system that is a venue, and it's the only thing we've ever found mechanically that could do that.
How? Talk to me about, chime in here, Craig. Let's
Exactly.
Chime in from the development side. Like, where did Perio Protect come from? I want to know the history of the company. If you know this info, how was it developed, and how has it progressed in its development to where it is today?
Yeah, so there's a dentist named Dr. Dwayne Keller, and he's a dentist in St. Louis, now retired. But when he was practicing, he was doing surgery, periodontal surgery on his mother.
Oh.
And he did a quad scaling, replaning. Mother said, "I'm not coming back for any more of this.
Oh.
Figure it out. I can't do this anymore." Like, she was uncomfortable. She didn't like it. And so he started thinking, he's like, well, I don't really know of anything else. Like, how can we do this without doing scaling and replaning? So he started having these ideas of, okay, if we can get something down there that still keeps the patient comfortable, but also gets a good kill on that bacteria. And they went through all these tests and trials and tried all these different things. And they finally landed on, he thought, oh, what if we made a tray that had a seal that went all the way along the peripheral edge of the tray? So if it has the seal, that means that nothing can escape the tray when you put something in it, right? And then he had an idea to make an extension as well on the tray. So the deal is, our Perio tray, whatever you put in the Perio tray can't get out. And then that kind of that begs the question, well, what the heck do you put in the thing, right?
Yeah.
What do you put in the tray? So we tested all kinds of different medicaments, and we started with antibiotics, right? We started with doxycycline because we thought doxycycline was the answer, because that's just what it was. We were using doxycycline. So we started putting doxycycline in these trays, and then we had the idea of using hydrogen peroxide. And we thought, and we got these great results back. We're like, this is amazing. I mean, this is working. These trays are actually holding it and pushing the medication down. Doxycycline is a lifesaver. But then we realized that it was actually we call it Perio gel. It's a 1.7% hydrogen peroxide gel that was actually doing all the work on killing that bacteria and getting good kill on the bacteria. So we actually have shifted since when we first started the company 20 years ago. Now we almost exclusively use Perio gel, and it's just a 1.7% hydrogen peroxide gel. There's no other active ingredients. And what's great about hydrogen peroxide is that there's no bacteria that are resistant to it, right? So we have patients wear these trays on a daily basis to help have a better chance of fighting and going deeper than the 2 millimeters that Dr. Lau was talking about. So
Interesting.
that's how it started, and that was the quick version of where we've kind of ended up.
And it's not as simple as just saying, well, they're just trays.
No.
I've been at your booth for a little bit, and a bunch of people came by and said, oh, I don't need your trays. I just want the gel. Like, how much is just the gel? And it's like, no, because it's not going to do the same thing. If you have like a suck down machine at your office and you're making whitening trays for people, you're not going to be able to make them to this level. And the quality of them is amazing. So talk to me about what the answer is to people that try and do that. Like, are you actually even getting the gel where it needs to go if you don't have that seal?
No, you're not. I mean, because if you think of hydrogen peroxide, right? Think of a cut on your hand.
Sure.
And you pour hydrogen peroxide on it. What happens?
Goes everywhere.
It bubbles up. So think about doing the exact same thing in a tray that doesn't have a seal.
Yeah.
It's going to slowly bubble up, and it's going to get all over your mouth, and it's not going to get where it needs to go. And that's why the seal, that's why our patent is on the seal. That's why the seal is so important, is because if we didn't have that, then it would just leak out into your mouth.
Yeah.
What happens is the hydrogen peroxide over the course of about 15 minutes, which is the wear time on the tray, slowly is releasing oxygen. And that oxygen is being forced interproximal and subgingival. So it has nowhere else to go other than into the sulcus. So, and what happens then is you're introducing oxygen into an environment that does not get oxygen.
Yeah.
At home. The patient can do this at home, which is kind of a game changer, right? Because we have toothbrush, rinse, and floss, and
all of the things.
All the things,
Yeah.
right? And just like Dr. Lau said, these are great tools, and we're not saying not to use these tools.
Yeah.
But what happens when you have a situation where a patient has pocketing that goes deeper than that, has an infection that goes deeper than that? They don't have a fighting chance at home to get there and take care of it. So now you're seeing this patient every 3, 4, 6 months, whatever it is. You're getting them all cleaned up and sending them home, and they may be doing all those things, but it just
not
doesn't
enough.
get deep enough. Right?
Yeah, absolutely.
that's
So the
the
wear time
problem.
is 15 minutes. Is there like a recommended duration? How are you finding this, Dr. Lau, in Perio protocols? Like, at what stage does someone begin using Perio Protect? The beginning, after scaling, and for how long? What does the company
Well-
recommend versus what have you seen anecdotally in your practice?
Well, there's a company recommendation and there's Sam's recommendation.
Which is what I'm asking. So what's
So
the
why don't-
let's
why
start
don't
with
we
the
go with
company. What's the
time to
official?
debate?
Yeah.
Yeah, I mean,
Drop the gloves.
All right. So let me say what we typically say.
Yeah.
So what we typically say is you start the patient out at twice a day.
Yeah.
Once in the morning, once in the evening. And then once they make it through their first tube of Perio gel.
And how
which
long does the tube
that should
typically
take
last?
that should take around 3 weeks
Okay.
if you're wearing it twice a day.
Got it.
Then you drop them down to one time a day. We call that the maintenance
You
phase.
do that at night?
And then
Prefer night?
night or morning.
Doesn't
I mean,
matter.
Just
The bacteria
what
doesn't
I
care.
always tell hygienists, what I always talk to, it's like just make sure they wear them.
Yeah.
Just wear
Anytime.
the things. It doesn't matter when. Just do it.
Yeah.
But we try to fit it into a schedule. So if you shower every day, if you watch Netflix every day, if you do this or do that, then just wear your trays while you're doing that thing so you can tie it to a schedule. So it's a daily thing.
Got it.
So that's the company suggestion. Now I'm actually very interested in what Dr. Lau's about to say. I want to hear what you
Well,
say.
the number one issue, as you well know, is
Uh-oh.
compliance.
Compliance.
Yeah. Patients just like to do whatever the heck
No,
they want.
people like to do whatever they want.
Right.
Guilty.
You too?
Yeah.
Yeah.
And if you read Atomic Habits, have you read Atomic
I
Habits?
have. Yeah.
I have
James
too.
James Clear's a cool guy.
It's a good one.
So you know.
Yeah. A 1% change over
There's
every
four
day.
things, right? It's got to be easy, it's got to be obvious, it's got to
Right.
be attractive, and it's got to be satisfying.
Yeah.
Well, I'm not sure of those trays.
I guess it's satisfying if they start to see the gradual whitening of the teeth. That may be the
Exactly.
satisfaction part, but you don't see it right away, right? It takes time.
Takes a bit.
Right. But let's face it, that
It's a good side effect to have, right? Of
yeah,
any of
right.
any of them.
it is a good thing because there it creates some type of, to a certain degree, instant gratification. I personally would rather have them using it once a day
And be more consistent.
and 10 minutes
Okay.
because the science is there. But whether it's 10 minutes or 15
Does that extra
minutes,
5 minutes make
that
make
science
that big,
is
right.
not as strong. Now, truly, as Craig says, is if you were starting out, now let's work backwards because part of this is what I just created for Perio Protect and other groups. Wouldn't you agree that it totally depends upon the patient?
Sure. Yeah. Like, well, a chronic
And-
perio patient versus a gingivitis patient.
And so what I did was I created protocols using the AAP classification.
Okay. That's good. So what would a stage and grade change be between from 1 to
Well, naturally, the further we go up on the scale and the stage, the further we go up on the grade, the more we're going to push it for them to use it, at least initially, twice a day.
Mm-hmm.
But I know people. Do you know the study that was just done on flossing in the United States?
Yeah.
Patients of record? 7%.
Sweet. That's a good number. 7's a lucky number,
That's a-
isn't it?
7%.
Best number ever.
Yikes.
So if you think, say, I would rather someone do oral irrigation
Yeah.
and do it every day.
Yeah.
Even though some hygienist is going to debate me over flossing again.
We had oh my gosh, what is his name? Also a periodontist that his like spoiler clip was that flossing is useless. And that's what he says, that comparatively irrigation with some sort of water irrigation device is going to be much more efficacious at removing biofilm than string floss.
Only if both groups did it, I would debate that.
I mean, the science is the science. It was a meta-analysis of I don't even know how many, 54 different pieces of research in it, and all were unbiased, not paid for by water irrigation companies. So, I mean, that's what science is saying, and it was published in the newspaper too. Like,
well, that's a really good reason that is published in the newspaper.
Well, it was published after the meta-analysis came out, but the conclusion was that at removing biofilm, generally speaking, floss is not as efficient because of the patient's poor techniques. So they're not C-shaping. They're not going up and down 10 times. And we see it. Like I see it when a patient says, well, I floss frequently, and they have a straight cut through the center of their papilla because they're treating it as a one in and one done.
Exactly.
We're not here to debate flossing. We're here to talk about other things that are much more useful in long-term effectiveness, which I don't think floss is. I think it's been around for a very long time, invented in the dentist's basement.
We perpetuate what we've learned.
Sure.
And if you speak, and as I do every few weeks, speak to a large group of hygienists, new hygienists, different hygienists, if you say floss, like you just gave that dialogue,
my little spiel, they'll rip me apart.
They're having arrhythmias.
Yeah.
But
you should see the comments I get on Instagram.
But the point is, and relative to what Craig is saying, though, is that if you could do something, that you could put something in your mouth and continue doing whatever you were doing
the rest of your life.
And if you go back again to Atomic Habits, if you could figure out how to fit that into your day, you would have a better chance at it. But I'm a practical periodontist. It depends upon what they walk in with. Now, am I going to sell more Perio Protect if we say every single body on the face of the earth should use it? Yeah, but we're practitioners who design care to a patient's condition. And the thing I love about the classification is for the first time, they included risk. And we never had risk before.
Yeah.
So this whole thing is about risk. The number one risk factor in perio is genetics.
Yeah.
It always has, always will. And it's the same for any other medical condition, isn't it?
Mm-hmm. Absolutely. And the more risk factors you have, the more comorbidities you have, the more difficult it is to manage, especially in that older age, quote unquote, older age. You live in this like system of dysfunction for so long that patients come in and they're like, well, all of a sudden, all of these things are happening. And it's not an all of a sudden thing. It's a just in time thing. Like your body's been trying to fight off as much as it could for as long as it could. And now it's just in time. Like those things it's time and tide, right?
But the genetics rides number one.
Right. But you don't see a 21-year-old with aggressive perio. You see a 21-year-old with the early stages of periodontal disease. And if not managed and mitigated early, that's when you end up being a 50-year-old or even a 40-year-old starting to lose teeth.
Right.
So it takes time. It's a faster slope. You're definitely going up, that slope faster than anyone else. So age bracket wise, when would you recommend this?
Well, one of the areas though, don't let me forget about implants.
No.
The age bracket, I don't know.
Well, how early?
As a periodontist,
I mean, you don't.
One of my specialties
teens.
was treating refractory, rapidly advancing periodontal disease. I had a lot of folks in my practice that were 35 that had 80% bone loss, 9 millimeter pocket depth separation, do everything possible. It's still about genetics.
Yeah.
It's still about genetics. I've had 95-year-olds that never did anything.
Yeah.
And there's no bone loss. So when you ask me which patient, no doubt it's the patient that you feel has the best opportunity for needing something adjunctive. But I'd also go back to compliance.
Yeah.
There are people that's going to wear a tray before they do oral hygiene. Right?
Yeah.
All you got to do is pop it in. I mean, it's not a lot of work.
It's easy.
I mean, let's think about it. Oral hygiene is one of the most difficult personal grooming things that exist in life. All I'm asking you to do is pop this tray in.
Yeah. Yeah, it's pretty simple.
Pretty simple.
Is there a, so let's backtrack. Is there an age minimum for someone to, because we can start treating as early as gingivitis, right?
Oh, absolutely.
So let's say you've got a 16-year-old post ortho, brackets have all come off.
Yeah.
Like
Totally.
would
why
you
not?
use that then?
Yeah, for sure. Absolutely. Especially if they have, if they have signs of bleeding, right? Because that's what we're looking at infection. So we say Perio Protect. If you have 10 or more sites of bleeding, then you're a candidate for Perio Protect.
Yeah.
You're a candidate for trays. Because if bleeding is a sign of infection, then we have to address the infection. So there's no, as long as they have their fully erupted permanent teeth, then there's no age, because we're using hydrogen peroxide. That's the thing. We're not using anything that's abrasive, and we're not ingesting anything either. So, as long as they meet those requirements, then they're a candidate for Perio Protect for sure.
Interesting. Pregnancy?
Oh yeah. Yeah, because pregnancy gingivitis, right?
Yeah.
That's a huge deal. And
And
like I said before,
it's sensitive. I have some active patients that are in periotherapy now that are pregnant, and just they're so sensitive to tastes and they're sensitive to sensations that they're having a hard time brushing, and they're sick all the time in that first trimester.
Yeah, and hydrogen peroxide is made naturally in our bodies, right? So there's nothing. There's no contraindication.
What's the difference between Perio Gel X and Perio Gel proper?
Magic.
Original?
It's magic.
Magic.
No,
unicorn tears.
That's right. How did you?
How did I know you have a secret unicorn in St. Louis?
Perio Gel. Okay, so this is the original Perio Gel. This is what we've done all of our research with. This has been around for 20 years. And along the journey here, we have figured out in dentistry that xylitol is awesome.
Oh,
right? Xylitol is super cool. So we've been having requests to make a medication that has xylitol instead of the original formula. And we just haven't done it. And we finally did in 2020. We came out with Perio Gel X, which is essentially a version of Perio
X is
Gel.
for xylitol. Wow, I get it now.
X is for xylitol.
Oh, it took me a minute, but look at me go.
I know, I took a while. We finally got there.
The blonde roots.
So Perio Gel X has xylitol in it. There's nothing clinically different about it.
In what concentration is it? It's not enough for it to really be.
It's not enough to address caries or anything like that. But it is xylitol. It does have a little bit less of a mint flavor.
Yeah.
So if there's someone who doesn't really like the mint thing, then this is probably the medication for them. So there's some small differences, but as far as clinically
they're both
concerned, they're both the exact same thing. You still wear them the same time. But we have found that offices really do love the Perio Gel X. Just as having xylitol in it just makes it a little bit better.
Yeah.
But we still have a lot of offices that use the OG Perio Gel as well, and they both work just fine.
What's the research and science around the use of it for mucositis and periimplantitis, and how would one determine at what phase of treatment?
Not as strong as on the perio side.
Okay.
There is some out there, but there's no reason logically to think that it would not be effective. 1 year we find that the microflora is the same. The next year we find it's different between implant disease and perio. But it just makes logical, rational sense that being able to do something to manage implant, especially at the mucositis level, would be effective. And that probably the only time that you could not would be an all-on-X.
Yeah.
Everything else, there's no reason why you wouldn't.
As all-on-X fixed, can you make a tray that seals? No, you need a natural tooth.
No. But if you're like some of us who are pushing to stop the all-on-X screw retained as soon as we can, then that would be, because then you would have a system by which, say, I believe that implant-supported dentures should be removed by patients on a daily basis. And then there you would create a tray that would fit down on the abutments.
Right.
And here you go. But for all the other implant patients, absolutely would be effective. As you know, we're in an epidemic of implant disease. No one wants to talk about it, especially if you place implants or you're an implant company. But we're in there's another side to this coin. And who sees it more than anyone?
Hygienists.
You bet.
Yeah.
You bet.
Yeah, absolutely.
You bet. It's hygienists.
Yeah. Any company info on the implant side?
Oh, I mean, if you think about it, there's just no way to keep the threads and margins on an implant as clean as possible at home.
Yeah.
I mean, how
Hopefully
are we
don't have threads, but
yeah, right. Yeah, hopefully it doesn't get to that point. But how do you keep it clean? As clean as it possibly can be, right? So we always recommend, so a lot of our implant docs and implant offices, they include a set of trays when they put an implant in.
like a single tooth.
Yeah.
Okay.
Because
So it can seal around a single tooth.
Absolutely.
Okay.
Yeah, absolutely. And
What about
What a
like
great way
multiple?
to-
If you've got a bridge,
Yeah.
it'll seal.
Yeah, because we're really concerned with the gum line. So
Yeah.
we can make a tray to seal over that. And getting what better than to get oxygen and hydrogen peroxide into those crevices and creases in
Yeah.
between that implant to just keep it as safe as possible and to make the investment. I mean, you're already making this investment.
Sure.
So why not protect that investment that you're making in your mouth by getting a perio tray?
It's the hardest part, I think. Like we as clinicians and hygienists, dentists, we see the catastrophe that happens when things start to fail. But unfortunately, we're not always as I don't want to say anything disparaging to our listeners, but we work so fast that we miss a lot of the early stuff. For example, perimucositis around a single tooth or whatever, even an all-on X. It's very difficult to identify the redness when you're working in a 45-minute appointment and you're also taking x-rays and doing a full mouth probe and there's a recall. But did you do your fluoride? And are you meeting your time quota? And did you write your chart notes? It's just, there's a lot of moving parts in a hygiene appointment. And I find that our time keeps getting cut and cut and cut, but we're supposed to bill the same, if not more. So there's this struggle to miss the minute, like to miss the teeny tiny little things. I don't even know where I was going with that, but it's
I can tell you where.
difficult on the prevention side. That's what we're talking about.
We're
in a hygiene crisis.
Yeah.
We have continued to add things for what we want you to do. And we sometimes prioritize not in the best patient interest, but maybe sometimes in a financial interest.
Yeah.
And we're asking a heck of a lot out of someone who's there trying to get through it all. And if you look, we could go off on this tangent. If you look at the percent of practices that do oral cancer exams,
Mm-hmm.
I mean, it's really...
You'd be surprised. Some people don't even take blood pressure. I posted something on my Instagram and my Instagram stories, and only about 3,000 people on my Instagram stories vote or see anything. And it was me sitting in the dental chair with my blood pressure cuff on, just about to get my teeth cleaned on my lunch break.
Mm-hmm.
And the question was, how often do you take blood pressure? And the first one is not often as I'd like at every patient, only patients with medically compromised health histories. And then I'd prefer not to say. Mm-hmm. And the preferred not to say was quite high. So some people messaged me privately and said, I can't even get my boss to buy a blood pressure cuff, or patients are so accustomed to not having their blood pressure taken. So it's like something as small as taking someone's vitals.
Well, we'll go back, to Atomic Habits. You know the way to do blood pressure? You do it on every single patient that comes in. In our practice, suture removal, blood pressure.
Yeah.
Because if you don't do that, it's kind of like, do you do something weekly? Do you do something daily?
You got to do it every day.
You either do it or you don't do it.
Yeah, agreed.
And how many times have we sent patients to the ER out of a hygiene operatory? But speaking about hygiene and Perio Protect, though, and Craig knows, one of the things that we are doing is, think about this. If you've got a product out here, you've got to show it to the dentist, right? The dentist has to show it to the hygienist.
Yeah.
The hygienist has to show it
to the patient.
Okay. Those are three different talk tracks. So what appeals to a dentist on Perio Protect is not the same thing as appeals to a dental hygienist, and absolutely is not the same that appeals to the patient.
Mm-hmm.
So I always talk about, I was raised in East Texas. We have something called a dog in the hunt.
A dog in the hunt.
A
Is
dog-
that the dog that chases the what does that mean? I don't know what that means.
Well, you're a millennial. You would.
Oh,
A
Got us
dog in
again.
a dog in the hunt means that if I've got something in it for me, my chances are better that I am going to adopt it.
Yeah.
Okay.
Oh, because there's an incentive.
Exactly.
Got it. That's the dog in the hunt. You got it.
So
Okay,
I will
got
tell
it.
you whether you want to cut this in or out, because I've been working with Craig and group to analyze what is going on here. How do you get adoption?
Yeah.
How does this thing happen? And you know what we found? Where we see the most adoption of Perio Protect is when the dental hygienist gets some commission off of selling it.
You know, I'm going to cut this out. My hygienist that works for me is commissioned. She makes 30% of everything that she bills.
Absolutely. And that's, I consult. And my number one,
associates do that. Like I don't understand
my number
why.
one is it's not complicated. So what I designed was an algorithm of 8 questions that I can ask a dentist in the practice, and I can determine if, to a certain degree, whether they're going to adopt Perio Protect or not.
And what can you quickly, as we're closing up, just throw the 8 questions, but don't answer why.
I'm not going to give you all 8.
Give me
but
3.
I can
I'll
give
fill
you.
in the gaps.
I can tell you 1,
Okay.
commission.
Commission.
Yeah.
I can tell you 2, huddle.
Yep.
I can tell you 3, doctor. What's the percent of your practice is perio?
Yep. You'd be surprised how many don't know that.
How many hygienists do you have?
Yeah.
They don't know.
Yeah. Are you doing your own hygiene?
No. Well, some of them are now.
In survey.
Yeah.
but-
the end.
But if
Do not
you,
collect 200. Do not pass go.
what's your cancellation no-show rate?
Yeah.
Do you, and this is the one because I've created this. Do you have a perio protocol written down?
Written down. Yeah.
If you answer yes to those, because when Jess and I were working,
Yep.
you answer those, I can tell you, we're not only going to make a sale. The most important thing is, a year later, they're still prescribing trays.
We're gonna keep going. Right.
So here's the bottom line. Here's what I'm telling Perio Protect. Don't waste your time on those where it's never going to happen. Actually, that's a primary rule in sales.
Yeah.
Don't waste your time on folks that you know, but you're afraid that maybe no.
Yeah.
Move on to those.
Who are already doing it. Invest in the people that you
And,
have.
you know,
Yeah.
I could be
Willing, right?
very non-public health because I've always been fee for service.
Yeah.
You know
And
what?
most specialists, I mean, you're
No,
lucky.
no.
Yeah.
Why shouldn't you work on the ones who want
I know.
you to work on
I
them?
know. That's the struggle that we have in our practice now is trying to eliminate a whole episode for a whole nother time,
Exactly.
which I'm happy to do
Right at
at
this
another
table.
trade
We'll
show. Craig, one last question.
Go
So
ahead.
I'm new to incorporating Perio Protect into my practice.
Welcome.
Thank you. My last office used Perio Protect, so I'm familiar, but I'm not familiar with what it's like to incorporate it into a practice as the owner versus as someone who came in, got trained on it, and now this is what you have to do as a clinician.
Mhm.
So, as a business owner, what do I have to do? Where do I start?
Well,
Quick, like what's the workflow?
I mean, really, the workflow it's pretty quick, especially since you know about it already a little bit.
Yeah.
We have a quick thing that you sign, takes about 30 seconds, and then we need to get your scanner connected. Or if you don't have a scanner,
I have a
then
scanner. I have an Itero.
and iTerra, you type in like 5 digits and then connect that to our
Beep,
lab.
boop, boop.
Yeah, beep. That's exactly what it sounds
Beep,
like
boop,
when you
boop.
connect it.
Mhm.
And then really the biggest thing I think is getting your team trained.
Yeah.
So meeting on a webinar and just getting together and asking all the screening questions.
Yeah.
and maybe if those screening questions don't go well, maybe we talk about that.
Yeah.
And getting everybody in the same room and figuring out why you want to do Perio Protect. Like, what is the point? Why do you want to do this? Is this because you heard about it at a conference and you're excited about it? What do you know about it? Why is this important to you? And who's going to be the point person in the practice? Just things like that so that we can start the relationship. Because I
Yeah.
think that's the real important part about it is starting a relationship, because it's not like you're paying us, you're buying a big thing, and then you get the thing, and then we don't talk anymore.
Yeah.
This is going to be many patients, many trays. There's going to be back and forth, and this is going to be a long-term deal because it's long-term treatment for patients, right? They're going to keep buying perio gel. So we have to go through the business systems together and get the team together and on the same page. So I would really start with getting the team together and getting them trained up and making sure that everyone understands why this is important.
Yeah.
And that it's more than just a tray, and that we have patients here that we have an opportunity to really get them healthy and arrest this disease where it is.
Yeah.
Right. Like let's get to the point where let's have a no bleeding practice. Let's make bleeding unacceptable in the practice. Right. And let's start with Perio Protect and get everybody on that mission. So you're getting me going now. I'm getting excited.
I'm getting you going.
So I know we're
drop some
wrapping
links.
up.
I'll drop some links in the show notes below with how to find out more information, how to find a provider, or how to become a provider. And you've got some cool CE that's coming up too.
Yeah.
That Tanya shared with me that I'll link below.
Vegas and LA and St. Louis, and we're kind of all over the place, and we live stream it, some of it too. So if you can't make it out, we can, it's for CE.
That's great.
That's on our website.
Wonderful. Well, thank you both for being here. And now I don't know if you know this, but my podcast is called the Tooth or Dare podcast.
I enjoy that.
Yeah,
That's
and
good.
for a reason. So at the end of the show, we have these tooth cards. They're supposed to be truth.
Kind
truth
of
or dare. See what I
intimidating.
did there? You
I
pick
like
a card, and they're not dental related. They're kind of fun.
Okay.
And you have to answer it.
Finally. Just kidding.
So pick your cards, each of you. Who's going to go first? Oh, he goes to the front of the pack. Okay.
Is it two?
Oh, just one. Which one do you like? Okay, there we go.
I can't do this one.
No? Okay. All right. Oh, okay.
I can do it.
I don't like to talk politics.
But you can't.
I don't like this one.
No.
I want another one.
You get one.
No, I don't like this one. I'm breaking all the rules.
Well, wait a minute. Give me.
That's it. You don't get to choose which one you like. This is the whole point of this. It's the game of chance.
You have to take the cards
you
away.
Take the card. The end. I'm putting them down my shirt. Okay, so Craig, I enlist your services first. All right, read it up.
What have you done in the past that you're still embarrassed about?
Show us the card. Let me see it. There we go. Look over here. Hey.
Check it out.
What have you most embarrassed about?
I don't know why this pops in my mind immediately, but when I was in high school, I had a fascination with climbing on roofs.
Oh.
I just love to climb on roofs. I'm like, I want to get on that roof. I would find my way up there and I would climb up there. And one day I was climbing on a roof. And I guess I just wasn't paying attention.
Oh, no.
And I actually got arrested
What?
for being on a roof.
Whose roof was this?
It was just, I don't know whose. It wasn't like a residential home. It was it was a business.
Oh, like a business.
And I guess someone saw me climbing up on the roof, and like I was a
probably
fairly
thought you were
good
breaking
kid.
in.
Like I was just really adventurous and stuff. And I'm calling my parents. I'm like, why did you get arrested? And all my friends, why'd you get arrested? For climbing on a roof. Like I wasn't even doing something cool. Like I got arrested. So that's just still pretty embarrassing.
That is embarrassing.
I'll
give you that one.
It's just
getting arrested. If you're going to get arrested, it better be for something good.
It's like, were you stealing
was
something?
Was it worth
it? Were you doing something awesome? No. I just was kind of curious what was on that roof.
No.
That's what I was.
What you got here, Doc? What's your
I'm
question?
still back on the Freudian explanation of why someone would climb on a roof.
Oh, let's not overanalyze, Craig.
No, go ahead.
Show us your card here. What you got?
Oh,
what does yours
are
say?
you more attracted to a nomadic or settled life?
Okay, so
so the response to this is a level of schizophrenia. I can't say settled since I am like the highest you can get with Marriott.
Okay. Occupational hazard, unfortunately.
I can't say settled because I'm like 3.5 million miles with Delta.
Okay.
But when I do get home, I really just like doing nothing.
Yeah.
So I think many folks, I've never been able to just do one thing.
Yeah.
So
you're in the
I
middle.
have to split it. I'm in the middle.
Yeah. It's one of those things where like during COVID, I travel quite a bit too. During COVID, I was home and I'm like, I don't know what to do with myself when I don't have to be checking in for something and I missed it. Like I felt like I needed to go. Like I need to, like I'm home for too long. It gives people too much of an opportunity to start to hate me. I need to give them their space.
Yeah.
So I guess I'm with you on that one too. Well, gentlemen,
Thank you.
thank you so much for being here. I appreciate it. I'll link all of your information below if anyone wants to reach out to you. Or
Link it up.
yeah, let's do it.
Love
Okay,
it.
everyone. Until
Thank you
next
so
time.
much.
Peace out, peeps. Say bye.